This is the Etiology podcast. I am your host, Elka Kubaku, licensed social worker and psychotherapist. In this podcast, we explore divisive issues around food, health, and body image with the goal of mending relationships within the eating disorder recovery professional community and creating a space where a multiplicity of perspectives can coexist harmoniously. This podcast is uncensored and encompasses the political and ideological spectrum. If you believe something you hear is harmful or misinformed, please be respectful to the speaker. And also, feel free to reach out about recording another episode on the same topic from your vantage point. My hope is that if, as professionals, we can hold each other's stories with respect and compassion, we'll be better able to do so for our clients. The most fundamental question in eating disorder treatment is what works. Eating disorders are so painful and can be so fatal. We want to use the treatment that has the best chance of giving our clients their lives back. We live in a time when empirical observation can be used to answer this question as more and more research studies examine the effectiveness of various interventions. Family-based treatment, FBT, sometimes referenced as the gold standard for treating eating disorders, is a manualized treatment that gives parents the responsibility for restoring their child's weight and managing eating behaviors. Critics of FBT are concerned that in cases where a parent is abusive, neglectful, or psychologically unstable, this type of parental involvement may increase family dysfunction and in some cases enable a child's abuser. Others are concerned that FBT addresses only the eating disorder behaviors without understanding the underlying psychosocial dynamics. In this episode, Abby Sterrett Cooper discusses her experience combining dialectical behavior therapy, DBT, with FBT to help clients achieve tangible improvement while also navigating theirs and their family's emotional realities. Abby shares her history of struggling with an eating disorder while in an unstable family environment during a time before targeted evidence-based treatment was available. She speaks about how now she navigates complicated family dynamics and uses FBT and DBT to help parents support loved ones. Abby challenges the assumption that evidence-based treatment is rigid and distant and talks about how individualized, client-centered care is a key component of evidence-based intervention. Abby is a licensed professional counselor in New Jersey and Pennsylvania and a certified eating disorder specialist. She has been in private practice for 20 years, focusing on evidence-based, health at every size informed approaches to treating eating disorders. Her postgraduate training includes certification in FBT and intensive training in standard DBT, DBT for adolescents, DBT for families, and DBT for eating disorders. Abby is an early adopter of FBT and community private practice and of integrating DBT with FBT to empower families and manage the dysregulation common in treatment. Outside her practice, Abby served on the psychology faculty at Caldwell University in New Jersey for 10 years, teaching child development, adolescent development, and psychology, and designing the university's first positive psychology course. Throughout her career, she has been a vocal advocate of evidence-based treatment that is non-judgmental, stigma-reducing, and myth-challenging. Abby is a member of the International Association of Eating Disorder Professionals and has been active in the Academy for Eating Disorder for 15 years, currently serving as co-chair of its Special Interest Group Oversight Committee. This is our second time recording this episode, so to begin, we briefly reflect on our first time recording and what we'd like to shift this time around. One of the challenges in the current digitized climate is that the things we say become so solid and permanent. Well, as humans, we are constantly evolving. I know for myself, I cringe inside when I look at so much of what I've written or produced in the past. I hope that we can approach this episode and all the others with flexibility and forgiveness, recognizing that each of us is perpetually reflecting, growing, and changing. Hi, Abby. Thanks for joining me again.
Thanks, Elka. I really appreciate the opportunity.
Before we jump into the topic of family-based treatment, I want to check in a little bit about since this is our second time recording, are you willing to share with me and with our listeners what some of your reactions were the last time we had recorded?
Yeah. I know that I have strong opinions and strong attitudes.
Mm-hmm.
And I think that in combination with being vulnerable in a way that I'm not used to being vulnerable, right?
Mm-hmm.
Created so many reflections and thoughts and also then seeing yourself played back. How often do we have the opportunity to do that? Um, I had so many reactions to the recording
Hmm.
and
Yeah.
just thought, hmm, I was not, I don't think I was as self-aware as I wanted to be.
Hmm.
I think I was almost just let it rip.
Hmm.
And it's funny because a friend who watched the video said that she said she was concerned for me because she thought I had been very vulnerable. And
Hmm.
that wasn't as much of a concern for me as I felt some of the opinions that I put forward and the strength of those opinions,
Hmm.
and that I'd like to
That's interesting.
communicate differently.
Hmm. So when you were watching it, it was like, I'm afraid I appeared too forceful.
Aggressive or judgmental in ways that I don't want to be.
Hmm. Meaning when you were addressing questions that people who, let's say, are against or hesitant around family-based treatment, you felt like you were coming on too strong or making assumptions
Not
about them.
not about FBT because I am passionate about that. I think
Yeah.
more about where therapy is at in general right now. Right. I
Hmm.
think, and I think the political climate right now is having its impact on me
Yeah,
and a lot of us,
for sure.
and the economic
Hmm.
industry too. And I think it's fueling a bit of anger in me.
Hmm. Yeah. So as you were re-listening to it, you were starting to see some of the anger that you have toward the current political climate, and it felt like that was coming out in ways that were
Political
harsh.
and economic, yeah, yeah.
Mhm.
Some
And yeah.
business threads in the therapeutic um, industry.
Hmm. Can you get a little more specific about that?
Yeah, I mean, I think we're moving. Everything has become um, an opportunity for privatization and investment.
Okay.
And so what used to be, even in medicine, right, used to be your local primary care physician knew you, and it was a sole
Hmm.
practitioner, maybe a small practice, right? And you could get in with regular ease, and right, we know that's gone the way of the dodo bird. And a similar thing
Hmm.
is now happening in therapy, where being in private practice is a very, very different animal that it once was, and investment money has come in and created things like BetterHelp and Headway, and all of these companies are like it's okay for them to make money, just like it is in these medical complexes where now a venture capital company has come in and they're making the money, but the doctors are not doing as well. And
Hmm.
it's just a different model of doing business
Yeah.
where the clinician and the client are not the priority, the investor is.
Yes, I know that's something a lot of people have encountered in larger treatment settings. How was that expressed, or how did you feel that was expressed in your way of communicating the last time we spoke?
Well, I don't want to single out any one part of the therapeutic world,
Yeah.
and I think I might have done that.
Hmm.
And again, I was not my anger, I was not as aware of where my anger was and how it was impacting my communicating.
It's interesting for me to hear this because I'm not actually I don't actually know when you were talking about. I can't even I'm like trying to remember now our last conversation, a moment where it felt like you were attacking someone or um and
That's
then
I'm very
yeah.
grateful to hear that. I'm very grateful to hear that maybe it's something that I was more aware of in myself than you saw in me. So that's nice.
Yeah. So what you're coming away with from the last time is I felt like I was coming up across too strong, too judgmental. Some of my anger that I'm having at the way the therapy world is being, I don't know, monetized or used for business. And I was directing that at a particular group. And then what are you wanting this time? What do you feel like you'd shift?
Well, I'd rather stay focused on what we're here for, right? A
Mhm.
conversation that allows multiple perspectives and authenticity, and yes, vulnerability, right?
Yeah.
treatment and about the lives of our clients and how we can
Hmm.
improve their lives.
Hmm. Yeah, I hear that. So focusing more on my experience, both my personal and my work with clients, and how that shows up, which also the topic when you're talking about the therapy world being taken over business, that is like we can go into that topic. I feel like that would be a great conversation. And what I hear you saying is if we were to do that, you'd want to approach it directly rather than having it communicated more
Yeah.
subtly.
Rather than have
Yeah.
it infiltrate places where it needn't.
Yeah. In terms of what I'm coming in this time, I like we were both in the same conversation. And of course, my perception of it is totally different from yours. But I'm coming in like when you had emailed me with, I'd prefer to redo, but I'm okay with publishing it. There was a part of me that was like, maybe we should just publish it. I thought it was great. um, so what I'm coming in with is, and the reason I thought it was great was just, or the way that I gauge or assess a conversation is how much I feel like we're in contact with each other.
Mm,
And I approach therapeutic or therapy sessions the same way when afterwards, and you've probably experienced this as well after a session where you're like, it felt like I was really inhabiting that person's world, like we were on the same page, really able to talk versus when it feels like there's friction. So my hope coming in is that we can capture some of that again. And my fear is that because we're doing it the second time around, uh, it'll feel a little less organic, or you or me will have some like hesitation, like, can we get it right this time? So I just want
yeah.
to put that out there and approach it without any vision of right
I
and just,
I had that
yeah.
thought too. I felt like our connection was genuine, and I don't think that's going to be hard to have again. I think anytime you and
Mhm.
I sit in conversation, it'll happen.
Yeah. Yeah. And the other piece that stood out to me from that is when you're talking about, I listen to this and don't really feel comfortable with it. I I see you as a person, and you've told me you experience yourself this way as well, and hear this from people as you're not afraid to share something if you believe in it, and you will stand by it, even if you get pushback for it. So when you're looking at this and are like, this doesn't quite feel right, it's not so much a I'm afraid of what people will say. It's a this feels out of line with some of my own values.
Yeah, very much so.
Mhm.
Very much so.
Yeah.
I don't want
And
to
you've,
cross the line from passion to anger.
yeah. So that's the value there. I want to be passionate, but I don't want to have it directed at someone in a judgmental or critical way.
Exactly.
Got it. Awesome. Cool. So with that, let's dive into family treatment. Tell me, I'm also the piece of like, this is our second conversation. So I I'm like,
Yeah,
repeat the
you know
same thing.
answers now
Yeah.
that
Because
you didn't
like
know
I've heard some
then.
of your story, but other people haven't. So start by just can you start by just telling me in general what you do in the eating disorder world, and then we'll zoom in.
Yeah. So I think that my thing is evidence-based treatments.
Hmm.
So I have been trained by behavior tech, Marshall and Hands people in the standard model of DBT, um,
Hmm.
the adolescent model, the high conflict couple and family model by all of the
Hmm.
researchers and the eating disorder, or now what we're calling multi-diagnostic eating disorder, so MED, DBT, and
Hmm.
that was Lucine Wisniewski and Alan
Hmm.
Frazzetti's family. And so a lot of wonderful people. And I also was certified in FBT, um,
Yeah.
at the Institute, and yeah, trained and
Hmm.
certified. And I really believe that
Yeah.
if we are going to, well, and so here's the business piece too, a little bit. If we're going to expect to be
Hmm.
paid, and then people want to use their insurance, right? We should expect to be doing something where they can expect results. And of course, there's nothing in eating disorders where we can expect 100% results, right? For 100% of the clients. So we want to at least
Yeah.
start where we have some knowledge, right? To suspect that we are
Mm.
going to make a difference.
Yeah.
And I felt like I
Yeah.
owed that to people. Like, to use evidence-based treatments is the most compassionate thing you can do because it holds out the best hope.
Yeah. I want to actually zero in on that. And maybe we'll even set aside family-based treatment. We have a couple other people coming on about that and focus more broadly on evidence-based treatment because I've been having a lot of people come on from the other side of individualized care. We've been through the system, whatever that system is, and have been hurt by it. And now we're wanting to. I'm seeing your facial expressions. Can you tell me
I
what's
know. I
running through
wish I
your mind
could.
as you're speaking?
I don't have a good poker face.
No, that's good because we can go deeper into that. Tell me about it.
Yeah, I think there's a false dichotomy, right? A real non-dialectical stance around individualized evidence-based, right?
Yeah.
Those are the two poles. And
Hmm.
I think that's false.
Tell
Um,
me.
DBT is a
Tell me how
framework,
you've experienced it. Yeah.
right? And I don't think it looks exactly the same with any individual or family.
Hmm.
And I
Yeah.
think that the stance from DBT about that the client is the expert in them, right? I
Hmm.
might be an expert in eating disorders generally or a treatment model, right? But they're the expert
Yeah.
in themselves. So how can it
Hmm.
look the same every time? It is by definition individualized.
Okay. So the framework then is I have these four, let's say in DBT, I have the four different skill areas where I have tools to help people develop them. And the client is the one who's the expert on themselves. So I'm going to tell me what that looks like, or in what way does that
So
impact the way you're approaching it?
DBT is not just the skills. It's really a worldview and a perspective. And
Yeah.
individual therapy in DBT is not done like standard talk therapy, right?
Hmm.
Client and the clinician agree on a set of target behaviors that they're going to be tracking with a diary card. I don't impose those goals, those target behaviors on the
Right.
client. They decide, right? We might disagree,
Hmm.
right? A client might
Yeah.
agree they want to work on maybe purging, but they don't want to look at their
Hmm.
substance abuse, right? Or
Hmm.
use because we're not agreeing that it's abuse. Okay,
Yeah.
I have to go with what they
Mhm.
want to target with some
Yeah.
caveats, right? Certain things like we know that self-harm and suicidality, we have to agree that that's a priority,
Hmm.
right? And DBT
Yeah.
has a treatment hierarchy.
Hmm. Yeah.
Again, it's a collaborative process of coming to what the goals are. And then actually the diary
Hmm.
card helps me as the clinician set the agenda every week based on that person's week. That's my eagle eye view, right? As opposed to
Yeah.
the person coming in and saying, oh, I want to talk about this. Well, maybe we're going to get to that if it's on the treatment hierarchy, but maybe we won't because there
Yeah.
are higher priorities to deal with.
Okay. So when we're talking about the evidence-based piece, we're approaching therapy as there's a system for how I can help you and how we can focus the treatment. So we're not just talking like friends or coming in and venting every week, but then not really seeing changes in your life outside here.
Mhm.
And the individualized pieces, you get to decide what you're coming in here for. And I'll work with you on that so that we can meet those goals.
Right. And we always give the client autonomy to say, I don't want to do this anymore. And that's not their failure,
Mhm.
right? They haven't failed
Yeah.
in DBT. And I
Hmm.
think there are lots of other places, especially in DBT, where the client makes a lot of choice and has a lot of autonomy,
Yeah.
right? And the relationship becomes even more authentic, if you will, by virtue of
Hmm.
coaching that is embedded in it, right? It's not that you leave my office and then I don't see you for a whole week or hear from you the whole week or have no relationship
Hmm.
to support you all week,
Yeah.
right? We have the coaching built right in. The expectation is I'm there for
Yeah.
you.
That feels like a massive piece that's missing from a lot of therapy. And
Mhm.
I mean, I'd have a hard time implementing it just because of the structure of my own life, but I can see where it would be so helpful to have something where people can call you and use what they're learning in session in the moment when it's happening.
Right. And one of the places that I think it's been very useful from what I've seen with my clients is the integration of FBT with DBT. I have a colleague,
Hmm.
Jennifer Campbell, who also does both of these treatments, and we're presenting on this at the Academy for Eating Disorders in May about this integration and how to maybe change the pace of FBT to
Hmm.
accommodate where a young person might have a very complex presentation where there's self-harm involved in the recovery
Hmm.
process and aggression and some of these more difficult things to manage. So
Hmm.
this integration of saying, okay, we're going to slow down FBT, we're going to bring in some DBT principles, and we're going to be able to move forward and back and forward and back. And that's kind of the flow that DBT
Hmm.
teaches you as a clinician,
Yeah.
right? To
Yeah.
balance the
That.
acceptance, the change, the let's stay here for a minute. And okay, now it's time to move forward. How do we do that?
Hmm. Yeah. That feels like it speaks to a primary concern that I've had and have heard from a lot of people as well, is when we're using something that's very behavior based with someone who has a really deep and complicated internal emotional world.
Mhm.
So you're starting to work on a model or integration of models where there's more space for that.
Yeah, I think a lot of us are doing this.
Yeah. Can you rewind? You've trained a long time ago, or like trained as a therapist.
Not as long as it looks, because I came to this as a second career.
Okay, fine. So I don't know then how much of a movement toward evidence-based treatment you've seen, but
Yeah,
what was it like when you were training, and
yeah,
what led you to this place of like, if I'm doing something with someone, I want to know what works.
yeah. So I actually my training was about 25 years ago.
Okay,
So
so it's been a
that is
couple
a
decades.
significant chunk of time.
Yeah.
And I think that in my um, youth, when I was
Mhm.
struggling, it
Yeah.
was the Wild West. There was
Hmm.
still the predominance, despite CBT being well recognized, right?
Hmm.
And DBT beginning to be recognized, right? There was still a predominance of community clinicians providing some form of psychodynamic or eclectic
Hmm.
treatment that was tantamount to shooting the shit.
Hmm.
So in my history, I had therapy that never once asked me about food or my eating habits, despite
Hmm.
kind of, that was what I thought I was there to get help with, among other things.
Yeah. What did they do in that therapy where they didn't ask you about food and eating habits
What
or
I,
whatever you're comfortable sharing? Yeah.
right, I found that what most therapists want to talk about is family dynamics,
Hmm.
right? Um,
Yep.
and perhaps we know a lot more about genetics now than we did then.
Hmm.
uh, as well as neurology and neuroscience in general.
Yeah.
Uh, but that, and don't get me wrong, there was enough to talk about. I'm sure it
Of
was very
course. Yeah.
entertaining, enjoyable, and satisfying for the therapist.
Hmm.
But I don't know that I don't know, really did anything for me. I mean,
Did you appreciate it at the time, or to what extent did you appreciate it
I just,
versus resent?
I don't know if I appreciated it at the time. It just seemed like what you needed to do.
Hmm.
And there wasn't little I didn't have any knowledge or awareness at the time that there was anything different.
Hmm. Yeah. So you spent a lot of time talking about family dynamics, which there's
Mhm.
always what to talk about there.
Right. In my
Maybe
case, there was. I mean, there was a lot. And when I was sick, I remember thinking, I wish my parents would take notice. If I got sick enough, maybe they would.
hmm.
But I had those thoughts.
Yeah.
Um, but there was no FBT then.
Hmm. Yeah. So there was, for you, there were family dynamics at play, if not causing the eating disorder, then affecting the way it was or wasn't addressed.
See, I still look at that thing about causing an eating disorder as kind of like,
Hmm.
I think it's a it's disservice to talk about it that way.
Yeah.
Was it a neglectful, emotionally abusive environment? Yes. However,
Hmm.
I could have equally had a substance use disorder, but I didn't.
Hmm.
Right? There are lots of ways that could have manifested that trauma.
Right. You can never establish a single cause really to anything
Yeah,
in mental health, and going down that route also doesn't really give you a practical path forward. It can be sort of intellectually stimulating and interesting to think about, but it doesn't give you
exactly.
anything.
Exactly. And now I know that it's likely that my mom probably had some form of an eating disorder, though it wasn't apparent at the time. I only found
Yeah.
this out later. And a first cousin on my mother's side of the family has had an extensive history with an eating disorder that came out later after mine. Um,
Hmm.
but we didn't even barely know each other growing up. So,
Hmm.
as opposed to environmental influence or what have you, there's genetics here.
Yeah. There were stressors in your life that may have contributed in the way that your family was. I know you had mentioned the last time we spoke that your mom was a complicated person.
Yeah, my mom still is a narcissist. And
Hmm.
she also had bipolar disorder, which was undiagnosed until I was in college. So there were times when she would be bedridden for, weeks at a time, and that's the time we all longed for.
Hmm.
When she was on the manic side, she was very irritable, and that's putting it nicely.
Hmm.
She was left in the side hall was cause for screams. So
Hmm. We spoke about this last time, and it's still sort of baffling to me. We had spoken about oftentimes the challenge that people have with family-based treatment. And in some ways, this translates to evidence-based treatment as well, is with family-based treatment, you're giving parents control over what their adolescent child is eating. What happens when the parents are abusive or
yeah,
psychologically unstable?
right.
And when you describe my mother was a narcissist, if I left something out that would have been cause for screaming, how do you imagine that would have played out if she was given the sole control and responsibility of what you were eating?
Yeah, I think my parents both are incredibly bright people. Uh,
Hmm.
and I think that it may have been useful to understand what was happening as it was. They didn't know I was ill. I think they didn't want it. It was an inconvenient truth, right? Um,
Yeah.
but to me, again, this control narrative, I think, is something that I
Hmm.
don't buy into. I don't think we're giving parents control. I think we're giving them responsibility. And that's the thing my parents didn't take was responsibility as parents.
Hmm.
And that's the
Yeah.
thing I longed for, that they would be the parents.
Hmm. You feel like they wanted that as well.
I don't think, the 70s were a strange time, the late 60s and early 70s. If you've ever seen the movie The Ice Storm, it really depicts it kind of well in middle class and upper middle class, suburban kind of communities. But there was, they called it the me generation for a reason. So
Hmm.
I think culturally there were really different factors. The kind of parenting we see today that's almost the polar opposite, where parents are
Yeah.
involved in micromanaging every aspect of a kid's life. It was,
Yeah.
yeah. So I don't know if you can separate out culture from their individual personalities and needs and whatnot. But that's
Yeah.
why if a professional had said, well, you know, we need to be, looking at this and taking care of, and can you do this, that, and the other thing, they might have taken it up. They might
Hmm.
not, but they might have. And it's worth the try.
Yeah. Yeah,
right?
worth a try to get some involvement and some of the people closest to you to notice that there was something wrong.
Exactly. Exactly.
How do you how do you imagine it would have played out in like this is maybe this falls into the realm of pure speculation, but I'm asking because it is. I want to say the major hesitation people have around family-based treatment, but let's say your mother was in a manic state and
Mm.
you were really not and I'm totally throwing this out of or like making this up, but you were like really not wanting to eat and she's like, I have to make you eat. How do you imagine that playing out? It feels so sticky, even just thinking about it.
So I don't know I've ever heard a parent say, I have to make you eat.
Hmm.
That's just
Yeah.
not how it's implemented.
Yeah.
I mean, the guidance that I think those of us who are certified provide to parents is that this is done with kindness, love,
Hmm.
empathy, right? Compassion,
Yeah.
patience.
Hmm.
It's modeling a strength. I think about basements in the old days in houses where they have those concrete poles sitting in the basement in the middle of the floor, right in the middle of the room,
Yeah.
and then wrapping it with pillows. The pole's not going
Hmm.
anywhere,
Yeah.
but we're going to make it nice and soft so it doesn't, so you don't smack into it.
Hmm. That feels like a much deeper work than just teaching parents what your eats is now your responsibility, and here's how you hold that boundary. And maybe this is where you use the DBT, but this is going to be tough, and here's how you maintain yourself through it.
Right. I think that's a big piece of it. I think a lot of parents who have come to me after saying they've done FBT, which is no different than people who've said they've done DBT before and they didn't
Hmm.
with some form
Yeah.
of DBT light. And I think the same thing happens with FBT.
Yeah, I've definitely seen that with DBT light, and it was a little bit of a turnoff for me, I want to say, because I had approached actually. So I had an eating disorder as well, binge eating, and had started out very much reading, seeing a therapist who was eclectic, didn't really know about eating disorders, didn't really get anything from it, and then found sort of on my own through reading things that had really helped me and really helped me understand in a targeted way what was causing the binge eating and how to work with it. So I had gone or started out very deep on the skills based cognitive behavioral therapy. I had read DBT and was looking at it. I was like, this is the answer. And I had one of my teachers at the time would talk about borderline as like the thing that we never want to work with. He's like, he was an older psychologist. And
Hmm.
uh, so I had gone, and mindfulness was probably the biggest influence for me.
Yeah.
So I had come in very much on the skill side. And I feel like I've I've sort of moved back and forth between the two because as I've gotten further away from the eating disorder and it's just not something I'm working with directly, it feels like things like my work is more subtle, more relational, and happens to be now that my supervisor is deeply, deeply psychodynamic. I almost want to set up a conversation between the two of you. But
Would love that.
um, yeah, I totally forgot where I'm going with this. Um, Oh, I was talking about the DBT light. So yeah, I had come in very much and DBT I like just in the sense that it has that dialectic and is a little bit less of just the sort of change your thoughts or you can argue with them. And then when I did my internship at a treatment center, there was the DBT light and it was with teenagers and it was the group that they all hated. And it was like it
Right.
so did not work.
So one of the things that I love about DBT is that it allows me to be irreverent and to have a dark sense of humor and to play with it.
Hmm.
Right. And
Yeah.
that works with teenagers really well.
Hmm.
So if you're not
Yeah.
infused with that, the core of DBT and the worldview, the perspective, the dialectical aspect of DBT, teaching skills becomes
Yeah.
this boring, stupid, you know, yeah,
Hmm.
acronym
Yeah.
laden, formulaic thing.
Hmm. Can you give me an example of the dark humor and also how the DBT framework allows space for that?
Yeah. So even something simple, right? A teenager is bemoaning their sibling, right? And oh, I want to kill them. Well, if you kill them, then they're never going to do the chores that they're supposed to do, right? You're going to end up with all the
Hmm.
chores, right? Like
Yeah.
the idea is to shift energy,
Hmm.
right? And that breaks through.
Yeah. Hmm. Yeah. You can shift to a place of playfulness instead of a teacher student or what is it about the DBT framework that lends itself to that?
Well, I think that is the DBT framework, right? This movement, it's constant
Hmm.
movement between acceptance and change, and
Hmm.
want to facilitate movement with whatever works,
Hmm. Yeah.
right? And again, you might not use sarcasm or irreverence in the first few
Right.
sessions with the client, right? You need to build a relationship. Hence, once
Yeah.
again, formulaic, not rigid relationship building, right? And you
Hmm.
find out what works with that client. And also, once a client gets to know me, they might value humor
Yeah.
more than they did at the beginning.
Hmm. Yeah. So, in terms of what DBT is and how it allows for that flexibility, there's the movement between acceptance and change, with the emphasis in this moment in this conversation being on the acceptance piece, where I don't have to approach every session with, like, this is what you're struggling with, let's change it. We can also meet and hold that space together where you're struggling. And also, there's a pragmatic aspect to it that I'll move with you and structure this relationship and build this relationship in whatever way is going to work, in whatever way is going to speak to you.
Being effective is what matters.
Hmm. Yeah.
Right? Yeah. So I think that's really helpful with FBT, because I think a lot of times parents, this is what I've heard, is that parents who have tried some other FBT have often felt
Hmm.
very, we want to increase the activation of parents, that
Hmm.
it's serious and that this is a crisis, right? But some parents get so
Yeah.
overwhelmed by that burden of responsibility, right?
Hmm.
They're afraid to do anything.
Hmm.
So making enough time, space, room for their fear, right? Their anger,
Hmm.
all of these, where you sit with that enough for the acceptance, right? Before we
Hmm.
ask them to change.
Yeah. The parents are really your patient or client
Client,
in that case.
yeah, exactly. I
Yeah.
am their consultant. Right? And I
Hmm.
feel like DBT, it's a little similar too. Like I'm their consultant.
Yeah.
They're the expert on them.
Yeah.
So and they're both non-judgmental,
Hmm.
right? And I have had parents come from other FBT who said they felt judged.
Yeah.
They've like they were continually being told they weren't doing it right or they weren't doing it good enough.
Hmm. Yeah. I've seen that.
Right. And it is
Yeah.
interesting, as a parent now, I have two kids in their 20s. And so now I have the perspective of not just having been the young person, having been the child, right? But now I have the
Hmm.
perspective of what it was like being a parent and the
Hmm.
intense feeling of responsibility and the need to try and get it right.
Yeah. I feel that working with parents now in terms of the responsibility and also, like, I so get the challenge when parents come in to their child's treatment burnt out. I'm thinking back to when I was in school and my daughter would get sick and I'd have to take off like the day before a paper was due or something. And I'm like, if you magnify that by something that really takes over your entire life, like if you're like, I can't go on this trip that I had planned, I can't go to work.
I left my doctorate
Like,
because I had a 1-year-old and a 3-year-old, and we didn't have the money and the
mm,
ability for good child care. And my husband was overwhelmed by the extra responsibility. And so I had to stop. They came first.
mhm, yeah. So you can empathize with parents that are coming to you and like, I don't want to put my life on pause. And also just like this reinforce or restate this is just what we need for your child to survive.
Very much. Very
Mhm.
much.
We had spoken about this from through the lens of your experience of what it would have been like to have a parent involved, even a parent who was narcissistic and had bipolar. Can you tell me about, and I know you can't speak about individual clients, but maybe like pull together a story from different ones when you've encountered clients where the relational dynamics or were either really dysfunctional, not because of the eating disorder, but pre-existing to that, or the parents had just a lot of their own like really challenging mental health personality stuff.
I think more often than not, when that happens, I get fired.
Okay, say more.
And I've had this happen often, especially with parents that have a very high level of anxiety, and who have very much bought into wellness culture
Hmm.
and diet culture. And so I've been
Hmm.
fired for advocating for, giving Oreos with lunch. What do you mean?
Oh.
They'll- they're not healthy.
Hmm.
And the more I advocate for a wide variety of foods, and all foods are good foods, and try and help them accept that. Like, we're not saying all she will eat is Oreos.
Hmm. Yeah.
But I think
Hmm.
that, if our culture, just like my parents, lived in a certain time frame when they were parenting, right now we are absolutely flooded with wellness, nonsense
Yep.
and what is
Hmm.
healthy and unhealthy. And everything seems to have such oh, what's the word? Any decision you make is so loaded.
Yeah. There's so much information behind it, information, misinformation. So
Misinformation.
yeah. So when you've had clients or parents where the parents had a lot of their own stuff going on, it wasn't so much the concern that people often have, which is that the parent will take this responsibility and it'll become another form of abuse or giving power to the abuser. It was they just, and this makes sense to me as you're describing it in a almost, I don't know, more, I wouldn't say more gentle, but kinder, as a kinder approach where you're really working deeply with the parents and their emotional reality. So it wasn't like you're telling the abuser, like, take full control of your child and then they'll like run with it. Um, you were
No,
working with them on how can you stay fully present and help your child move through this fear that they have. And when parents had a lot of their own stuff going on, they weren't able to hold that, so they just leave.
yeah, that happens quite a lot.
Hmm.
In general, like when I say quite a lot, I mean I've heard this from colleagues, right?
Yeah.
That they just um and they often then think, um, this person doesn't know what they're talking about, and they continue to look for other providers.
Hmm. Yeah.
And so a lot of times, those families do end up in a more traditional treatment environment, right?
Hmm.
Wanting a child to be in a higher level of care,
Yeah.
which of course FBT was designed to try and avoid.
Hmm. Yeah. From that end, it feels like it can be really helpful, even to people who've had really bad experiences in higher levels of care or have just like cycled from one treatment center to the next and have the experience of missing out on their entire lives.
Yeah. I mean, and heck, you can't live your whole life in a treatment center. You have to ultimately go home, whatever that is,
Yeah.
right? Or be able to create your own home life at a
Hmm.
certain. And if the
Yeah.
pattern established that you can't do it, and that treatment centers are the only place where it's possible, how's this going to happen?
Yeah.
And I think this model now of using family, right? It's the research has now extended through the college ages, right? And into couples
Hmm.
treatment with the UCAN model and the Lauren Hill's model, which is Laura Hill, temperament based, and it uses
Hmm.
family involvement as well.
Hmm. What's the UCAN model? I'm not familiar with that.
Yeah, that's at that was in one of Cindy Bulick's Center for Excellence in Eating Disorders, where they
Hmm.
research using a similar kind of approach with partners, even parents, siblings, whoever in an adult, a clinical population.
Okay. Interesting. Yeah. It's a it's a tough position to be in. I'm thinking about like I have seen, and I don't know what this was caused by, but I have seen people who've had the like family responsible for your eating and like it has put a real strain on the relationship and given parents that exhaustion of like firstly this is my responsibility like you need to be telling me everything and if you're not like sort of approaching the child in a very harsh way because of their own frustration and also like a feeling of just like I've missed out on my life like it had sort of escalated the emotional quality which I know is not what's supposed to happen when you talk about that pillar wrapped in bubble wrap uh, but I have seen that burnout happen which makes me wonder what do you say is the or what have you seen in terms of trajectory of FBT, and I imagine there are studies on this as well. Like when you're talking to a parent about you're taking responsibility for your child's eating, is that for a, and I'm sure this varies also, but is that for an indefinite period of time? Like, what do you expect that to look like?
Well, obviously the treatment manual has a very specific time frame,
Right.
right? Rarely had it conform to that time frame.
Mm, yeah.
So it can be extended, absolutely. Um, can take more than a year, can take 2 years, right?
Hmm.
I still think that's better than what was the research that it was an average 7 to 10 years of treatment in traditional.
Yeah.
Yeah. So still seems to be an improvement.
Yeah.
Um, but I don't
Can you
think
describe? Yeah.
it's not forever. And we see stages of improvement,
Hmm.
right?
Yeah.
It's not a stage one, everything is managed by the parent for the entire length of
Hmm.
treatment. That's not the point, right? It's a three-phased treatment, right? There's a
Hmm.
period of co-management, and then there's a period in phase three where it's a return to typical adolescent management of food like any other teenager.
Yeah. Can you tell me about what that first stage looks like and how it does or doesn't fit into other aspect of the child's life and the parents? So, like parents work, child's school, parent being fully responsible. Like, how does that fit into people's life? What does that typically look like?
Yeah, so sometimes we call it home hospital, phase one.
Hmm.
I know the folks
Yeah.
at CHOP that I've worked with because they're geographically within a,
Hmm.
they're within range. So they come out of CHOP where they've needed medical stabilization, which is very scary, right? And so that can sometimes enhance motivation.
For
Uh,
sure.
and so basically then we become home hospital. And
Hmm.
so that means nothing else happens, right? We're not using any more energy than we're taking in. We're minimizing how much we're using. So we're kind of sitting around all day, right? It's three
Hmm.
meals, three snacks, right? Parents are
Hmm.
providing everything. The child's not involved in choice or preparation. And it's pretty
Hmm.
intense. And some families have had the flexibility to be able to manage this more simply than others. Some have needed to take FMLA. Some
Mm,
have put in extended family members, right?
yeah.
And parents have used each other or other family members or very close friends. And once we get a gain rate
Hmm.
that seems steady, stable, we can start adding in activity. We can start going back to school. We may still have to have lunch monitored at school or come home from school, right?
Hmm.
So this gets shaped gradually, right?
Yeah.
I've seen that sometimes phase two gets stuck when too many things are handed back to the teenager too soon. And it's so scary, and the
Hmm.
eating disorder voice just roars up again.
Oh.
There was a
So it's
comment.
a complete pause from life in the beginning.
I'm sorry.
It's a complete pause from life in the beginning. And that's typical for a child who's in a severe state, even if they're at a treatment center. But here it's the parent as well, is either the
Right.
parent or hopefully if they have some other support or two parents. I
Yeah,
can't even imagine being a single parent in that situation.
I can't either. I mean, it is hard. I have feel for them. I've
Yeah.
seen it done with a grandparent, and I've seen it done with other family and friends when it's a single parent.
Yeah.
And I've participated in that, and it is very, very challenging. However, it's not that different from any life-threatening illness and what is needed for
Right.
treatment,
That's
right?
true.
So, right. And I
That's
think we
true.
forget about that this has the highest mortality rate, right? For any mental
Mhm.
illness. Well, now second to opioid abuse, but yeah.
Yeah.
So again, we really do need to reorient life because of that risk level.
Hmm. Yeah. I can also see it being really empowering for parents.
The
And I
parents who
do feel like,
work
yeah,
through this,
what's that?
I mean, I
Hmm.
still get texts and emails with pictures and just look how wonderful she's doing still. And
Hmm.
I can't thank you enough kind of thing, which is just,
Well,
just an amazing thing to ever hear. You never expect to hear something like that.
yeah.
And it's a blessing.
Hmm. I do wonder, and I'm thinking about it myself as a parent. Like, if my child was in that situation, like, I'd want to have something tangible to do for them. And I've seen parents come with this as well. Like, can you just tell me what to do? Um, I'm wondering if it self-selects, as you're talking about it, if it self-selects when you talk about parents that drop out for parents who like have some degree of self-awareness and willingness to meet their child.
I don't know. I've seen some huge shifts in people. I
Mhm.
have no crystal ball on this. We have no
Yeah.
way of knowing who, you know, there have been times
Mhm.
where I thought, oh, wait, there's no way this is going to work. And then it does. So I think it's a
Mhm.
bit presumptuous on our part to think we somehow know. I
Yeah.
think that's why I keep thinking it's worth the try.
Hmm. Yeah. Can you give an example of that? Of, and again, you can mix and match stories, but of a parent who came in and the way they presented were like, is this gonna work? And then how that
Well,
played out or
I've
what
seen
kind of shit.
couples
Yeah.
with high conflict divorces,
Hmm.
right? Post-divorce, and they've been able to
Yeah.
work together. Right? I've seen
Hmm.
couples that after successful, effective FBT treatment, they then got divorced. I didn't know that they were on the verge of divorce before this started.
Yeah.
Who would have figured?
Hmm.
So it didn't change
So,
their marriage, but it certainly helped them come together to help their kid.
mhm. Yeah. Have or to what extent have you seen like where the parent-child relationship was, I don't know, I'm just picturing, let's say, a parent who is like verbally abusive, highly critical. Have you seen that where, let's say, a parent comes in like very shaming messages toward child, and how have you navigated that, or would you?
That's where Alan Frazzetti's model of the high conflict couple and family comes in. It's an immediate like, oh, time out, right? And we can send the child
Mhm.
out. Okay,
Yeah.
guys, let's talk about some things together here. Let's talk about language.
Yeah.
It's and let's talk about anger because the
Hmm.
anger is so understandable. This is frustrating as hell,
Yep. Hmm.
right? So
That makes, yeah, that makes so much sense to me.
right, somebody has to
And
intervene, right?
yeah.
Otherwise, what are you doing? You're taking the child and sending them away with the impression that somehow they're to blame for this. This is their problem,
Yeah.
right? Versus, no, this is a family's problem.
That's so counter the like fantasy of what FBT is that I've encountered and maybe been guilty of holding to some degree for myself. But and that's where I can see that I'm going back to that bubble coated pillow pillar feels like it's not a way of enabling a child to be abused. It's actually a way of standing up for them. Where as the therapist, you're holding that same stance where it's like, I'm strong enough to pause a conversation that's happening in middle and take a break so that the child doesn't have to witness something that they shouldn't be. And work with the parents on both letting them know that's not okay and also validating their experiences and working to change those.
Right. And again, that goes back to my fantasy that somebody would have intervened on my behalf, someone with strength and authority and more power than I had.
Yeah. 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 And it would not have been somebody going to telling your mother, okay, like you take all charge of her eating and just like make her eat. It would have been somebody who's able to also look at the dynamics of what's happening between your parents and you and really work with your parents on being able to support you.
Right. Because, in FBT, we are taught that this is not about changing the family dynamics. But yet, every time there's an effective FBT treatment, it does seem to shift the dynamics.
Yeah.
So, and I think that attending to the parents' needs in an authentic way, in a true way that really takes the time for that, is how
Mhm.
you get to have effective FBT.
It's the only way. And that, yeah, that also acknowledges that there is both need and space for some deeper work when we're talking about a manualized treatment. Deeper work, maybe not in the sense of let's uncover all your childhood trauma, but in a much more targeted way of if you're approaching this relationship with your child with a lot of blame, what's feeding into that and can we work with that?
Yeah. Yeah. And it's not that I don't have parents mention things like, when we talk about setting limits and behavioral principles around meals, right? And that, wait, set out the portion you expect him or her to have. And parents have quipped with me, oh no, and this is my mother saying there are children dying in India, right? So you have to finish. I was like, I know, right? It could sound like that. How do I not make it sound that way, right? And so there's the irreverence from my DBT. There's the validating the mom's experience and that, yes, it's going to bring up those feelings, but we're not taking a
Yeah.
side track, going off tangentially and now digging deep into the parents' food stuff.
Yeah. You're acknowledging what's there as it comes up and working with it as it directly impacts their ability to care for their child.
Right. And we started a conversation a little earlier today about, how long ago I was trained in the arc that I've seen in the
Hmm.
treatment community and science and whatnot. And it's kind of interesting because I almost feel like we've come full circle in a way that
Hmm.
has me a little worried, right? And I was
Yeah.
saying that when I was young, there was not really a huge implementation for evidence-based treatments, and we didn't know as much as we
Hmm.
do now. And so I saw, mostly through my window through, I became a member of the Academy for Eating Disorders in 2010, and I've become very involved in leadership roles and whatnot. And what I found there, what I discovered there was this sense of like the Holy Grail. Like these are people that are actually researching this, and these are clinicians who actually believe in like science. And
Mhm.
there was information out there. There was something better than shooting the shit and trying to uncover deep roots. There are other ways to go.
Yep.
And so there was a huge, huge fight on the listserv community on AED over FBT when it started to become very popular. Uh,
Hmm.
and as it started to emerge as an effective treatment. Oh boy, all out knockdown dragouts um, about those toxic parents and thing. Well, it was really not nice, not pretty. And it's interesting watching younger generations of clinicians and researchers coming into the field now. And there seems to be this rejection of evidence-based methods,
Hmm.
treatments, because of this idea that somehow it's formulaic and not individualized, or because all research is flawed because it was not all inclusive,
Hmm.
right? And to me, that's like throwing out the baby with the bathwater. Yes, we can all agree
Yeah.
that there needs to be more.
Hmm. Yeah. And I can see where that would be people's experience of it if it's done by a clinician who either there's not good rapport, just because of different personalities, or the clinician sort of like there are certain I don't know the common factors type of things, but there are certain things that just make a clinician a good one, regardless of what model you're using. And like, so I can see where it can come off as just very prescriptive, very by the book, if there's not some of those softer skills. And that's where people bounce back and are like, okay, like, stop reading from a manual. Just like relate to me as a person, or I want to
Yeah.
relate to people as a person.
I mean, I know that I'm constantly checking in with clients, whether it's DBT, FBT, CBT, no matter what I'm doing. Does that make sense to you? Right? I'm
Hmm.
constantly asking that.
Yeah.
And am I getting it?
Yeah. I have a couple of questions that are coming up for me, and then we'll start to wrap up. But so one is the other when we talk about the evidence-based versus, I mean, you're saying evidence-based isn't visualized, so we'd have to name the other side something else, but evidence-based versus, I don't know, intuitive or relational care is, and I've seen this and to some extent experienced it myself, where people talk about like the eating disorder in the case of substance use being the answer to something underneath it, to some way that the person's struggling. And I've had heard from people who are like, okay, like I've addressed the eating disorder and then I developed a different eating disorder or a substance use problem because there was something underneath it, or the pain I was carrying or whatever that pattern or experience is that was still feeding into or required some form
Yeah.
of coping. What have you experienced with?
But that's it. It's the coping,
Yeah.
right? All of this is about finding a strategy to cope,
Yeah.
right? Hopefully becoming less maladaptive and more effective,
Yeah.
right? And so I think if we can give up life-threatening behaviors, that's a step in the right
Mm.
direction.
Yeah.
And so I've worked with teenagers in FBT who have contacted me later
Hmm.
and said, you know, you once said that if there were things we wanted to talk about once the eating disorder was gone, if I had other things I could. Are
Hmm.
you still open to that? And I've been like, yeah, of course. Right. So
Hmm.
now it's, oh, she's now getting involved in relationships and romantic relationships and isn't, you know, doesn't have the best of communication skills and wants to work on
Hmm.
things absolutely developmentally healthy to work on.
Yeah. Hmm.
And so that it's done in an effective way.
Hmm. Yeah. Would you say that when it comes to working through those deeper things, is it that when you eliminate the life-threatening or address the life-threatening behaviors, which were used as a way, maladaptive way of coping with some sort of pain or something underneath it, is it that there's then sort of a space where those life-threatening behaviors had been that you can now fill with something else? So maybe now, and this was sort of an experience for me, just to make it more tangible. When I had stopped binge eating, I was using mostly mindfulness to stay with urges. And I started to notice that as I'm staying with urges, I'm also feeling some other things that are painful. Um, so there was sort of the space where, like, I'm there's almost a void that's left where
Mm.
I'm not using the binge eating anymore, and I can still feel this pain. And maybe that would be a space to do some deeper work on what that was and how to navigate it. So do you find it's like that where there's sort of this void now where now the person is able to confront their pain because they're not covering over it? Or is it more of a, and maybe some of both of these, that as you're working with, like, so let's say in the case of FBT, um, you're not using restriction anymore. It's just not an option. Um, are there new skills that you're giving the child alongside that? Or are you starting, at what point are you starting to does that
Yeah.
question sort of make
Well,
sense?
in a world, let's say, for instance, body image concerns, right? They often linger.
Hmm.
And
Right.
again, in 1985, Ruth Striegel Moore, that was her name at the time, said that women's body dissatisfaction is a normative discontent.
Yeah.
Mm. So there are going to be things that we all struggle with, we all deal with.
Right.
And some of this almost feels
Yeah.
existential in nature. What's the meaning of life? What are we here
Yeah.
for? Right? Meaning
Right.
and purpose.
Yeah.
Right? In DBT, we would call it our life worth living goals. Right? Which makes it sound a little
Yeah.
bit more practical and concrete, but it doesn't necessarily mean it is a practical, oh, I am here to
Right.
read books, right? No. Right? It can mean these loftier, more existential kind of ideas, values.
There will always be, and there will always be pain. And to what extent are you working with um, that underlying pain versus just teaching the person to let it be? Is there, like, to what
So,
extent is there an acknowledgement of whatever's underneath the eating disorder and how to work with
so
it or stay with it?
there's also a
Mhm.
presumption that there's always something underneath an eating disorder, and I'm going to push back against that. I've had
Yeah.
people come into treatment with an eating disorder that they got from losing a few pounds after getting their wisdom teeth out, or getting their tonsils out, or mono, or right, COVID,
Right.
right? Because they have the genetic vulnerability and whatever finely tuned machine, right, got sent out of whack chemically in the brain from just a little bit of malnourishment,
Yeah.
energy suppression, just a little bit.
Yeah.
And there wasn't anything underneath.
Right. So in that case, the FBT alone was or would be the answer. Like
Yeah,
once you're eating enough, you don't have the eating disorder anymore.
right.
Oh,
And
yeah.
but my goal is to go in agnostically, right?
Hmm.
Not to make a decision, eh, that I know where this is leading me. I don't.
Hmm. Yeah. And in cases where it becomes clear that there is something underneath or something more complicated, more emotionally complicated, how does that affect what FBT looks like and how it's implemented?
Again, I think that once we can get rid of that we know that when a malnourished brain is like that, it spikes anxiety, it spikes depression, it distorts cognitions. So we don't even have a fully functioning person there to work with
Right.
effectively.
Yeah.
And which is the gift of FBT and working with young people, right? You have the
Mhm.
authority people in the young person's life to
Right.
rely on. Working with an older adult without that alone and with that malnourished brain, that is really grueling,
Yeah.
right? The pain, the suffering, mm, with less
Mhm.
support and less help and less willingness because of malnourishment.
Yeah. So in the case where there's something underneath, would you say that the first step is, and this is essentially the DBT hierarchy, but the first step is work with that life-threatening behavior. And once they're at a stable place with that, then that gives you space to work with whatever deeper things were may have been
Absolutely.
underneath. Yeah, that
Absolutely.
makes
And I know other DBT providers who we all use contingency management, right? Learning principles.
Mhm.
And one of them is, you know what? Guess what? If we're not purging, right? If there's no purging this week, or maybe
Mhm.
much more reduced, maybe we can have an extra session where we talk about the other things you want to talk about.
Yeah.
So there are
Yeah.
lots of
So you're
ways.
acknowledging, yeah, you're acknowledging when they're there and um, have some sort of, I don't know, system for when we can get to them.
Yeah,
Hmm.
right. If you're following your meal plan and you've had a completion of 80% at least, we can do another session where we can leave the diary card on the table.
Hmm. Yeah. The final question. When it feels like when we have these like really I don't know, these debates where there's the two sides and the different, we're interacting with almost our own fantasy. And this might be grounded in real experience of what the other side actually believes and what the challenges actually are. So there's the fantasy of like what is wrong with FBT or what the challenges are, which I feel like we've done a pretty good job of covering. Can you tell me what are the actual challenges as someone who does FBT?
Yeah, I think it's true of DBT as well. The intensity
Yeah.
of the emotions that the clinician takes in.
Hmm.
And I'm thinking of the challenge from, my side of the
Yeah.
equation versus the families,
Right.
right?
Yep.
It
Yeah.
is a lot to hold.
Hmm.
It is a lot to hold.
Yeah.
And
And that
I,
speaks.
I think that a younger clinician maybe doesn't have children or maybe doesn't have a teenager, never has. I think it is easier for them to compartmentalize and maybe become a
Hmm.
little more judgmental about the parents. But I
Yeah.
think if you've had kids and you've raised kids and you've been
Hmm.
through whatever crap you've been through,
Yeah.
it's a lot.
Hmm.
It's a lot because you understand the parents' pain, even if
Hmm.
your kid hasn't had an eating disorder,
Yeah.
which my kids have not.
Yeah. That speaks again to the empathy in the relationship.
Right?
And
There's so
so,
much going
yeah.
on in that room and so much intensity.
Hmm. Yeah. And that shares a picture to me of you or the FBT clinician as somebody who is deeply invested and not that picture of somebody pulling from a manual or, you know,
Right. Yeah. I tell my FBT parents, I'm your coach. Right. I don't
mhm,
expect this to go as smoothly as we're talking about it or as it played out in front of me, right? In that one meal
yeah,
or two meal, right? Like I want you to reach out to me when the shit's going down.
yeah,
And that I get from my DBT training. I don't know how to expect to provide the kind of support they're going to need if I'm not willing to be there.
yeah,
And I don't think
yeah.
that's disempowering. I think that's empowering.
Thank you so much.
Elka, thank you so much for the first time and for this time.